Hello, everybody. It is Michelle Cornelius with Cypress Home Care Solutions. I'm the Director of Memory Care Programs, and I am here in our first ever partner interview with Cameron Svendsen, who is Chief Strategy Officer at Palliative Care Alliance and at Faith Hospice. And so we wanted to take a minute to talk with Cameron as one of our great partners here in the community, let you know what it is that they're doing. And Cameron, I want to start off with saying, wait a minute, two places here. Most of the time, hospice and palliative care are under the same name. They're in the same agency and the same company. You're working two places here. Tell me about the two and how they're related and how that came about.
All right. Well, it's funny because we did this a little differently. So we being our CEO and Executive Director, April Bowles, and I wanted to build a palliative care program because we saw the need, both coming from significant hospice backgrounds. We saw the need for this. We saw the gap in care where a person is almost needing hospice, not really meeting criteria from Medicare standpoint yet, but still struggling with things that relate to their illness. And so we thought, well, that's what palliative care is, and that's what it should be. And that's what we need to start for the Phoenix area. So our goal was to launch that, and we did 7 years ago. Can't even believe it's been 7 years already. But 7 years ago, we did that, and we pivoted a lot at that time in the industry. And I won't go into detail about that, but it did take hold, and we finally found some health plans that recognized what we do for the benefit of their members and started to reimburse us for the services that we provide for patients. So that's a very short story about how Palliative Care Alliance did get started, but the model is a nurse and a social worker, as well as a nurse practitioner, as part of the model of care for people at home that need it. And we were going along for about 4 years with this, knowing though that our background was in hospice and that many of our patients were going to need hospice at some point. And many of them did need hospice, and we were able to refer them over to various hospices around town. But honestly, there was a place for both, and so we were able to acquire a small local hospice and change the name to Faith Hospice. And so we are running two separate programs. Palliative Care Alliance has its own staff, its own office, its own set of patients. And so does Faith. Faith has its own staff and office and census of patients. So it's a totally different program, but sister companies.
Why not join them? What's the thought behind keeping them as two separate sister companies?
Well, are you familiar with transitional care?
Mm-hmm.
Okay, so
yep. Cypress helps with some transitional care cases. Absolutely.
Yeah. So, this idea of transitional care was started about a decade ago when patients were leaving the hospital, and the desire was to keep them at home and not let them come back, reduce readmissions. And so we looked, and everybody started looking. The ACOs around the country started looking, and they started being created to manage a set of cases of patients, to make sure that they could offer something at home. And so from a palliative care perspective, when you deal with chronic disease, serious illness, that isn't necessarily terminal, there's always going to be the risk of a person kind of recycling through the system, being admitted to the hospital, going home, be readmitted and going home because they have a serious illness. And if they're not meeting hospice criteria, there's no home-based program that is a long-term home-based solution. There's home health.
Sure.
And that's great from a coverage, a health plan coverage standpoint. But if you're going to get medical intervention for this, it really needs to be something with eyes on a patient in person, holistically speaking. And so,
well, and I know a lot of our folks want that type of intervention. They need that type of support and assistance, but the word hospice itself is still terrifying.
Right.
And so to call a palliative program where we know that we are not getting pushed to hospice, we know that we are still going to continue on with these treatments or these procedures,
Right.
and the goal is just to keep me home, I'd imagine is a big comfort.
Well, it is. I mean, for what Cypress does and what home care can offer in way of security for for people at home and staying at home, it's outstanding. I mean, there's nothing better than knowing that there is a choice and that they don't have to go out to some assisted living setting or some, outside of the home if that's not what they want. But medically speaking, if there isn't that intervention, then they're still going to be going out. And out right now is not where somebody wants to go. I mean, not just because that we're in the middle of a pandemic right now,
Right,
but in general, I don't think anybody says, "Yay, I get to go to the emergency room today."
right. No.
So it has become crucial. And I'm going to give a quick example of a patient. I got a call from a hospital today, and it was a palliative care referral, um, kind of an end stage dementia situation, a lot of behavioral disturbances for the caregiver who is a family member at home. Going to go through the Altex process of being, getting onto the program. But in the meantime, there's nothing to be offered, and so they called us and said, is this something that you can manage? And we definitely can. So that's a perfect example of getting somebody at home, keeping them there, keeping them out of the hospital, and letting the family know that there is a medical option.
And then you provide a nurse practitioner, and a social worker to
Right.
support the family in this situation. How often are they receiving that type of intervention? What does the program really look like for that client or patient?
Well, for the patient I just gave an example of,
Well, for any patient, how often are you providing those interventions and services? Is it a monthly visit?
it's actually more than a monthly visit. That was one of the things that we wanted to be sure of starting this program, was that somebody was seen weekly. Monthly is adequate, but I think when there's a serious situation, number one, they should be seen weekly, but number two, they should have access to a program 24/7, because we all know it's the weekends and the late nights and the holidays when symptoms exacerbate for whatever reason. So we didn't want to just say, you can call us from 8 to 5, but not during the Christmas break.
Right.
Um, so that's what we do. It is that, like you said, the nurse practitioner, the nurse, the social worker that are kind of, um, it's twice a month for the nurse. It's once a month for the social worker and once for the nurse practitioner. But because it's 4 times, and because our disciplines are talking to each other, we really get a good feeling of a complete understanding of what's going on with that person.
And then you said 24/7 phone calls can be made if there is that after hours emergency.
Right. So it's not
That's
that we're
great.
going to rush out to their home. It's not a dispatch health type of
Sure.
program, which is a wonderful program, and it's not an emergency room replacement, but it is a triage, understanding, and practice to be able to address things that are
Mhm.
happening. And we probably take care of these patients anywhere between 6 months and a year is usually what they are on with Palliative Care Alliance. And at the time, they either sign off and they don't need our services anymore, or they transition to hospice. That is typically what occurs.
Now, is this only in private homes? What opportunity do folks have for different settings if they're in independent living or?
It's a great question. So we always say residence,
Mhm.
because a person's home can be just about anywhere. So the health plans that we work with, which is currently the Alltex plans, Mercy Care, Banner, United Health, they would like for the patient to be in either a private residence, a group home, or assisted living type setting. So not a long-term care center, for the reason of duplication of services. They've got round the clock nursing in most of those settings. And so other than the skilled nursing setting, we are seeing patients wherever they are.
So it sounds like some of these folks might already have others involved in their cases if they're living in some type of an assisted living setting, whatever level of care that might be. There's often somebody there. There's somebody there for staff. So who can make the referral? Does the client have to call you? Does a case manager? Does the staff at the home? How should they get in touch with you and start this kind of service?
Yeah, no, that's another good question. I would say a majority of the referrals that we get are directly from the health plans. So directly from, let's say, Mercy Care, and they pick up the phone and they say, "Hey, we have a new member for you that we would really like you to start services for." We go out, we evaluate them, we explain what the palliative care program is. 99% of the time, they're going to agree to it because it is part of the benefit of the health plan. And then we start seeing them immediately. But on occasion, there are referrals from the hospitals or from like a home care company like Cypress, and sometimes just the community will call. And if they have the health plan that we work with, then we get a hold of the health plan and the case manager, and we go kind of the back way in and letting them know that we've got a patient of theirs or a member of theirs that needs it.
Okay. Now, if we switch gears and go to the faith hospice side, where the Palliative Care Alliance, through the all text plans, what about the hospice piece of it? Is that also community based anywhere the person resides?
It is, yes. And so hospice is a Medicare covered benefit. We work with a number of health plans, including the VA and United and some of the other health plans around the Phoenix area, Maricopa County. But it is different than palliative care in that you're really looking at a stage of an illness that becomes terminal.
Mm-hmm.
It becomes something that is totally irreversible and in its end stages or end stage. So if it's dementia, if it is cancer or respiratory illness like COPD or CHF or some kind of cardiac illness, that's what we're involved for. So the earlier we get called from the community, the better, which is true for hospice across the country.
Mm-hmm.
And as a country, we've done a lot better in the healthcare sectors of getting people involved earlier into hospice over the last probably half decade. I think we've seen an improvement in that area. We got a long way to go. It used to be that the average length of stay on a hospice was 18 days, and I think now we're at 27. So I mean, it's improving. But
it's improving.
if it's a 6-month benefit,
right,
we're still a ways out, and completely understandable. Obviously, doctors want to keep following their patients and don't just want to send them to a hospice. I think that there's a feeling of failure attached to that. So I understand it. But at the same time, I think we all recognize that we are mortal and that chronic diseases, if they're not going away as they worsen, the symptom management becomes a lot more important.
Mm-hmm. And one of the absolute things I love the most about hospice is that it's not only about the patient, but the family support, that it doesn't end when the person dies. There's ongoing support. And yes, we always want to see our loved ones comfortable while they're passing. And I've been with my grandparents as they've passed, and I want to see them not in pain.
Right.
But the family is still there, and the family is in emotional pain when that happens. And I know to have hospice involved has been such a benefit for my family. And I think that's one of the big pieces that people are starting to understand, that we can get on hospice to help the family, not
Right.
just the patient.
There was a misconception, and it still exists, but it's not as prevalent now, but I think it's important to what you just said. And that is that hospice is the equivalent of morphine, and
Mm-hmm.
that morphine is provided the moment that somebody comes onto hospice, no matter what their diagnosis is and no matter what their symptoms are. And while I can't speak for every hospice around town or around the country, I can tell you with certainty that pain medication is but one piece of what the hospice benefit is really about. The objective is to provide symptom management, but also the word comfort and the idea of quality of life. You know, the patients and the families, if you take everybody individually, which is what we have to do, the customization behind hospice is asking each patient and their family, how do you define quality of life? And if it's not about quantity, and clearly when it comes to hospice, it isn't about quantity as much as getting what they need at that time. And family dynamics are tough. You know, at end of life, everything is exacerbated and people are stressed and there's high anxiety. So getting a team in there that understands that and that can generate conversation with families to their loved one and vice versa is a big piece to what hospice intends to do from inception. And then after death, like you said, when somebody passes away, there's 13 months of bereavement follow-up support that is available to a family. I think it's probably underutilized, but that's par for the course in America, where there's just there's just a lot of people that don't feel they need to be helped, but we're there for them.
That's wonderful. Um, I want to say thank you for coming today, first of all, and ask before we wrap up, are there any last words, anything else you want to make sure people know about Palliative Care Alliance and or Faith Hospice?
Well, there's a lot of hospice companies in the area. I couldn't tell you exactly how many, but I'm sure anybody who has been involved with healthcare, they know at this point that there's a lot of competition out there. That's what it's called in the healthcare industry. But that's not what's important. I think it really is understanding it's about people. And if the people are, if it's a good fit, if it feels right, then that's going to be a good hospice for that patient. One thing that we did do is develop a legacy journal, a my life story journal, so that our volunteers can sit down with a patient and family, and there's 50 questions that span a patient's life. And we ask that patient every question as much as they want, as many as they want to go over, so that they can write in the journal or somebody can write the answers in for them and leave it behind for family. And it becomes their story.
That's wonderful. I love it.
And it's
The
what
social
separates
worker in me
us.
loves that.
Well, me too. And it is what separates Faith Hospice, one of the ways that Faith separates itself from others. So, I could go on and talk about more of those things, but I think that is a really exceptional example.
That is wonderful. So, if people want to get in touch with you with either Palliative Care Alliance or Faith Hospice, how do they reach out?
Well, I'd say a phone call is probably the best way. Texting, calling. I'm available 7 days a week. So 623-337-2583 is my phone number, and that's the only phone that I have. So it's personal and it's business, which is often both. 7 days a week.
Okay. Cameron, thank you. I
Thank
really
you, Michelle.
appreciate you being on with me today. I thank you for being the first that we're interviewing as part of this partner development. And I hope that this weather that we're having here in Phoenix, if folks don't know, we're end of October right now. It's finally cooled off a little bit, finally able to get outside and enjoy it and get out of the house that we've been kind of quarantining and isolating in for a long time. We want to encourage people to stay connected, stay
Definitely.
stay in touch, make sure that you're reaching out to folks. We understand the importance of being around people and being connected to people. We talk about this as physical isolation, not social isolation. So
Right. Right.
thank you for everybody who's listened on today. We appreciate your time. And you can get in touch with Cameron. Again, your number.
623-337-2583.
Or you can call Cypress and we can get you over to Cameron at 602-264-8009.
Thank you, Michelle.